Okay, so for chapter 46, these topics are going to be on irritable bowel syndrome and inflammatory bowel diseases. So those are two different things. But for right now, we're going to talk about IBS. And IBS is a general term given when there's no specific disease process pointed to, and you just have some upset stomach things going on. It's a cluster of symptoms. It fluctuates, gets worse with stress. Signs and symptoms are chronic constipation or diarrhea or alternating from both. There's usually no blood in the stool. Weight will be fine. Some abdominal pain, bloating, gas. So when they do a scope to see if there's something else going on, it'll be a normal exam. So no blood in the stool, no inflammation, and it does not increase the risk for cancer. They just don't have anything else to say about it but treat the symptoms. So for these clients, we'll just have them do a food diary and tell them to avoid the things that are irritating agents to them, encourage a diet high in fiber, instruct the client to keep a food diary and record their bowel patterns, and to change their diet based on or to prevent the signs and symptoms. Now, this one is Crohn's disease, and it is an inflammatory bowel disease issue. So this one has inflammation, whereas IBS had no inflammation and no signs and symptoms of disease process. They just have problems with bloating, gas, diarrhea, with no significant issues. Now, Crohn's is mainly in the ileum, so it is characterized by ileitis. So let's go over here and take a look at ileitis for just a minute. So ileitis is, gotta change my colors here. Hold on one second. Okay, so we're going to look at the colon. So here we have the cecum. The appendix comes off like that. Okay, here it would be the ileum, ileocecal valve right here. Then you have ascending colon, transverse colon, and descending colon, sigmoid, rectum, and anus. Okay, so here is the cecum. That's the large bowel. And then here is your ileum. So here is where Crohn's disease affects mainly. So if you're going to do a scope, you're going to put the scope in, it's going to go around, they're going to go all the way and then check inside the ileum for inflammation, okay? Okay, so with the Crohn's disease, it happens to be in the terminal portion. That's the part right there at the end. The inflammation is in through the submucosal layer and all the layers. So it goes all the way through the layers of the colon. Okay, so this is what makes it special. It goes through all the layers, submucosal and all the layers of the inflammation. It's in the ileum. Okay, they develop swelling and edema in that area. It creates cold ulcers, also called cobblestone appearance. So just a bunch of little ulcers together. And then they can develop fistulas. Fistula is a tunneling between one organ to another, mainly common around the labial, perilabial, and anal area. So that is opening between the vagina and the rectum or the anus. So that would mean stool would be able to seep into the vaginal canal. Usually they say this disease is autoimmune, and this because of the swelling and inflammation, it can create scarring and stricture and can lead to obstruction, which would need a surgical removal. So because of this disease being in the ileum, okay, so we're going to draw this again. Because the disease is here, and that is the right lower quadrant. So that's where the pain is going to be located. Right lower quadrant pain, abdominal distension, tenderness, chronic diarrhea, fever from the inflammation. They may have growth failure from malabsorption. It's hard to absorb things in your GI tract when it's inflamed. So with that also comes some electrolyte imbalances like low potassium also. It can involve the entire GI tract, including the mouth with mouth ulcers, and with children and teens can lead to growth failure. Usually appears in early adolescence. If it's swollen, you could palpate an abdominal mass. The main diagnosis here is going to be from laboratory work. White blood cells will be elevated. They'll have ESR rate will be elevated, the erythrocyte sedimentation rate. Those are inflammatory markers. May also have a CRP done. The C-reactive protein will be elevated. Barium enema to detect swelling and ulcers. An endoscopic exam, so in other words, a colonoscopy. So you have to do the colonoscopy to confirm diagnosis. In the colonoscopy, they can see skip lesions, ulcerations, and fistulas. So medical management is bowel rest if needed, TPN in severe cases, blood transfusions if needed. Medications would be to treat their symptoms. The main ones that are being used right now are Remicade and Humira, the biologic medications that decrease the immune system. And then corticosteroids is going to be your next line. That's prednisone. Patients may need an ileostomy, and that would be taking out part of the small bowel. So they possibly could have a short bowel syndrome, which means they would have a hard time absorbing nutrients. For nursing management, we're going to monitor for complications such as toxic megacolon. What happens in toxic megacolon is that there's a decrease in motility while having an infection. So if you have an infection in your colon, it slows down the motility, so the infection just sits there and brews. And as it brews, it releases toxins. The bacteria releases toxins, and the toxins inflate with air and carbon dioxide, and it inflates the colon. And that can become dangerous because it can stretch the colon out so much it can perforate. So we'll watch for that abdominal distension and swelling there to monitor for that. The next things that we have to monitor for bowel perforation. That can happen from the ulcers going through all the mucosal layers and then popping a hole in the colon. That creates peritonitis. So bowel perforation, we're looking for the signs and symptoms of peritonitis. So here are your key things for peritonitis and a bowel perforation. The patient will have a rigid board-like abdomen, have a sudden onset of pain. So they're going to have sudden pain, a rigid board-like abdomen. Fever will come. They'll be nauseous, maybe vomiting. Heart rate is going to shoot up. And their blood pressure may start to drop. Just depends on if they're going to go into shock or not. So we'll have to replace fluids, nutrition replacement. If this happens, you need to immediately call a physician so they can have emergency surgery. So we'll educate about stress reduction, diet modification, avoiding things that irritate the GI tract, and then we'll monitor their stool for any changes. Okay, for this question, the nurse is caring for a client who had a paracentesis. So that is where the needle is punctured through the abdominal cavity to remove fluid. Which of the following indicates the bowel was perforated during the procedure? Okay, so is it A, reports upper chest pain, decreased urine output, pallor, or temperature elevation? Well, upper chest pain is not correct because upper chest pain has nothing to do with the abdomen itself. Decreased urine output would refer to kidney issues and not necessarily a bowel perforation. Pallor is just paleness. It doesn't necessarily mean you have a bowel perforation, but the only one that does actually mean there's that gastric or GI contents that spilled through a bowel perforation into the abdominal cavity is temperature elevation. Now, ulcerative colitis is very similar to Crohn's disease. And with ulcerative colitis, it is a little different. It mainly affects the colon. So it does have colitis and colon in the name. So that will help you remember. It only goes through the mucosal and submucosal layers, whereas Crohn's went through all of them. This one is also an autoimmune disease. Toxic megacolon can occur here too. Signs and symptoms here, we have diarrhea, blood, and mucus. Okay, this one is specific with the blood and mucus. Although some patients who have Crohn's do have blood and mucus, but the blood and mucus is specific for colitis, ulcerative colitis for your textbook stuff. Ulcerative colitis patients complain of pain. They're dehydrated often, and they have incontinence during sleep, possibly. They have cramping and diarrhea after they eat, which leads to anorexia and weight loss, and also electrolyte imbalances from fluids in the fluid, not retaining it. They have exacerbations and remissions, and they mainly have left lower quadrant pain because it mainly affects the sigmoid. So if we draw our colon here again, okay, so if this is our abdomen, umbilicus, right here, left lower quadrant on the patient's body. So this will be the sigmoid here, and then the rectum, anus. That's going to be the main places where it comes up. Okay. Diagnostic procedures are exactly the same. They're going to have maybe just a sigmoidoscopy, or usually they're just going to have a whole colonoscopy. And treatment is actually the same. TPN, surgery, bowel rest, avoid spicy foods, that sort of thing. For nursing management, we must assess abdominal pain, stools, weight loss, diet, alcohol and caffeine use, bowel sounds, and palpate the abdomen. Okay, so we will also look at their skin, their mouth, assess their electrolytes. But here's where it becomes important. For these patients, make sure they do not have any laxatives or enemas. Okay, that's because it will make the pain worse. Okay, so laxatives and enemas are going to increase peristalsis, but they already have a lot of diarrhea, and that's just going to make their pain worse. Now, we do have a warning here, antispasmodics and opioids. So opioids and antispasmodics decrease stimulation. So here's the opposite. Give them laxatives, increases stimulation, makes it worse. Antispasmodics, which are to stop diarrhea, to stop pain. It also stops the colon from moving very well. So if we give them these drugs, they can have no way for the bacteria to leave, and the bacteria gives off a byproduct of carbon dioxide, which blows up the colon, and that becomes toxic megacolon. So we have to be very careful there. Do not give them anything that's an opioid or antispasmodic. For the patients that need an actual ileostomy from surgery, the ileostomy can drain as much as 1,000 milliliters a day. We want to prevent fluid volume deficit, so they need to be encouraged to drink more PO fluids, and IV fluids if they're in PO. But that's what they'll need to do, is remember that they can become very dehydrated because their colon is not going to be able to be there to absorb the fluid. So here's your picture of Crohn's disease and ulcerative colitis. Note Crohn's disease is the right lower quadrant for mainly affected, but can affect other parts. And the ulcerative colitis is mainly left lower quadrant, mainly affects the sigmoid and rectum. Now looking at the tissues, so here we have Crohn's in the middle, and you have the cobblestone ulcers, and maybe fissures and fistulas can happen here. And on the right, this is all layers. See, the line is going through all layers. And on the right, ulcerative colitis, it just goes through the baby layers there. Here's your question about colonoscopy. The nursing tasks include which of the following? Select all that apply. Would you give a gallon of Go Lightly in the evening before? True or false? NPO 12 hours before the procedure? Did it have to be NPO 12 hours before? We'll put a question mark by that one. Assess for allergy to contrast dye. Is that routine for colonoscopy? No, false. Clear liquid diet up to 8 hours before? Can they drink up to 8 hours before? Low-fat meal the morning of the procedure. Well, that's not with the colonoscopy. That's with the oral gallbladder series, isn't it? So that's a no. So here is the correct answers. So they can have a clear liquid diet while they're drinking the Go Lightly up to 8 hours before. They don't have to be NPO for 12 hours. It's usually 4 to 6 hours for textbook. Okay, after the colonoscopy, what are some nursing tasks? Ambulate afterwards, monitor for signs of colon perforation, offer food when no evidence of colon perforation is present, offer laxatives, provide fluids, or offer antiemetics. And here is the correct answers. We don't want to ambulate after the procedure because they're going to be sedated, so they need to wake up first. We do monitor for colon perforation in case the scope punctures the colon wall. We can offer food and drinks when there's no evidence of colon perforation. We don't need to offer laxatives. They just did a bowel prep, so that makes no sense. Provide fluids, yes. And offer antiemetics, no. They should not have nausea and vomiting. Okay, this one is the nurse is reviewing lab findings of a client who has acute exacerbation of Crohn's disease. Which of the following lab findings should the nurse expect to be increased with Crohn's disease? Okay, so Crohn's disease, inflammatory. So we're looking for inflammatory markers, hematocrit, erythrocyte sedimentation rate, white blood cells, folic acid, serum albumin. So which ones do we expect to be increased? Okay, the correct answer is ESR and white blood cells. The other ones, hematocrit may or may not be increased, but definitely our inflammatory markers, erythrocyte sedimentation rate, white blood cells. Hematocrit may be low if there's blood loss. And that's it.